Hello and welcome. This is Amanda Howell with Iatrix Systems. I will be your moderator today. If you should need technical assistance during the webinar, please refer to the information located in the questions section of your control panel. This webinar will be recorded for quality purposes. We do encourage you to participate in today's webinar by submitting your questions or comments in the questions section. For your convenience, we have uploaded the presentation in the handouts section of your control panel. Simply click the file name to download. And finally, after the webinar, you will have the opportunity to fill out a short survey to tell us how we did. This survey will appear when you leave the webinar. For your time, your name will be entered in a drawing to win a $100 Amazon gift card. And all of these drawings are held at the end of each month. I'd like to formally welcome you to our presentation, MACRA and Hospitalists. Are you prepared? Our speaker today is Cindy Paul. Cindy, a registered nurse with over 20 years experience in clinical nursing and public health education, is a consultant in our professional services division here at Iatrix Systems. She is experienced in hospital compliance and quality, including meaningful use and quality reporting programs. She also specializes in clinician workflow redesign to accomplish regulatory requirements. Cindy's primary role at Iatrix Systems is clinical consulting and project management for CMS quality initiatives. And now I'll turn it over to Cindy to get us started.
Thank you, Amanda, and good afternoon, everyone. Thank you for attending the webcast. Today, we'll take a look at different quality payment models, including MACRA, MIPS, and the Quality Payment Program. We'll review who is required to participate in these programs. We'll discuss different reporting periods. We'll look at some of the financial aspects involving the payment reimbursement or penalties, and how hospitals can accomplish this new quality reporting program and succeed. To start off, I'd like to just get some feedback from everyone with this poll question. Have you identified which physicians and providers are required to participate in MIPS within your facility? We'll just give you a few minutes there to answer either yes, no, not yet, or not sure.
Okay, Cindy's voting still going on.
Okay.
We'll give you a few more seconds there. Okay, looks like we've slowed down. So I'm going to go ahead and close the poll and share the results. And it looks like 45% said yes, 28% said no, 21% not yet, and 7% said not sure.
Okay. All right, so that does fall right in line with some of the recent statistics that we've been hearing. At HIMSS this year, Stoltenberg Consulting conducted a specific survey. They found that 64% of participants indicated they are not prepared for MACRA. Many providers believed that MACRA would be delayed or repealed, and so that was part of the reason for kind of waiting to start obtaining information and preparing. Of these respondents, 68% indicated preparation and compliance with MACRA should be a combined effort across clinical, financial, and IT departments. So you'll see there's definitely an emphasis here on establishing teams and eliminating somewhat of the silo effect that can often exist within hospital organizations. 31% of respondents stated new reporting requirements are their top challenge. And again, many of these challenges were establishing teams, where 29% of respondents said that motivating teams and collectively working together to achieve program goals was the second largest challenge. So let's just talk a little bit about MACRA, what it's all about. On April 16th, 2015, Congress passed the Medicare Access and Children's Health Insurance Program Reauthorization Act, also known as MACRA. This $214 billion law brought about several changes to healthcare reimbursement programs. The result was MACRA, or the Quality Payment Program, also known as QPP. The QPP shifts Medicare payments from what was before a fee-for-service model to a pay-for-performance model. Payments are based now on clinicians' individual performance of patient outcomes rather than payment for services based on volumes. Clinicians' focus now becomes care quality and improving patients' health. CMS estimates that MACRA will provide a savings of more than $39 billion over the next 10 years with the removal of the sustainable growth rate. And finally, on October 14th of 2016, CMS published the final rule. I also want to point out that MACRA was passed with bipartisan support. So any efforts to repeal or replace under our new administration are not expected. So let's take a little more in-depth look at MACRA and how we can break that down. So MACRA is a value model where clinicians have two different program options to choose from. There's MIPS, or the Merit-Based Incentive Payment Program, or alternative payment models, also known as APM. MIPS aligns three reporting programs previously known as PQRS, or the Physician Quality Reporting System, the EHR Meaningful Use Incentive Program, and the Value-Based Modifier Program. MIPS also added a fourth category called Improvement Activities. The second reporting option under MACRA is the Alternative Payment Model, or APM. An APM is a value-based payment model that provides incentives to providers based on their quality, outcomes, and cost containment. An APM focuses specifically on higher quality and cost-efficient care. It usually applies to a specific condition or patient population. There's also advanced APMs that tailor to small or rural physician practices or physicians who are also part of an ACO, or Accountable Care Organization. Under APMs, the financial rewards are greater, but there is also a greater risk. Through several conversations that we've had with hospitals and organizations the last several months, we've found out that most clinicians, especially hospitalists and hospital-based providers, are choosing to take the MIPS option. The big question is, do you know who is eligible to report within your organization? Since 2011, physicians, or eligible providers, as they were called, have participated in meaningful use and PQRS reporting within their clinics. Now under MACRA, CMS is changing the terminology and expands the groups of providers eligible to participate, now calling them eligible clinicians, or ECs. These clinicians do not always practice just within the clinic setting or within an ACO. Thus, there's a great focus now for evaluating and educating practitioners within the hospital setting for which providers or clinicians are required to participate in the new value-based model. Professionals that are subject to MIPS participation now include those working within hospitals like hospitalists, anesthesiologists, interventional radiologists, pathologists, emergency department physicians, nurse practitioners, physician's assistants. Those are just to name a few. Now, it's expected that in the coming years, this program will be expanded, and that will further include physical therapists, occupational therapists, other ancillary providers like audiologists, certified nurse midwives, and even dietary professionals. So the Quality Payment Program in 2017, who is eligible to report under MIPS? how do you determine who is required to participate? So the first step is to look at your clinicians within your facility. Those that bill greater than $30,000 to Medicare are eligible. Also, any providers that provide care to more than 100 Medicare patients. And then a side note is providers have to have participated in Medicare billing in previous years. So if 2017 is their first year to start Medicare billing, then they're exempt for this year, but they will be required in future years. So we've kind of just looked at a little bit high-level overview of the quality payment program. Let's just open the polls for another question. Do you have a plan to meet MIPS requirements for the quality payment program? Yes, no, you're not sure, or not yet.
Okay, Cindy, we're getting to about half of folks voted. Looks like we're slowing down here.
Okay.
We'll go ahead and close the poll and we'll share these results. So it looks like 38% said yes, 26 said not yet, 21 said no, and 15 said not sure.
Okay. So that doesn't really surprise me. Again, it goes back to a lot of folks have kind of been just sitting on the fence, hoping or waiting to see if MACRA would be repealed or if any changes would take place. Again, other reasons are hospitals are really focused on the other reporting requirements that have been in place within hospital facilities. And there is such a new focus with hospital clinicians now being required to report under MACRA. So it's all new information and it's taking time to kind of get up to speed on all of the new requirements. So this year is considered a transition year. So eligible clinicians participating in MIPS are allowed to pick your pace. CMS is allowing this track to provide different options so that clinicians can report on a specific period that best suits their practice or hospital culture. The size of the payment adjustment depends on how much data is submitted and the quality of those results. So for the first option, clinicians are required to report less than 90 days with a MIPS score of at least 3 to avoid a negative payment adjustment. Second option is report a minimum of 90 days with no penalty and possibly receive a positive reimbursement adjustment. And then lastly, the third option would be to report a full calendar year, which started on January 1st of this year, and receive a moderate positive payment adjustment. Or some clinicians have found it too difficult to participate this year, and they are just deciding to receive a negative -4 payment adjustment. I've also included a link listed here at the bottom of the slide, the QPP website. There's lots of information on the quality payment program on the cms.gov website. You can go there and learn more about pick your pace options and different quality payment reporting information. So let's just look a little bit more into the breakdown of how these payment adjustments are expected in the coming years. Again, for 2017 reporting, payment adjustments will take place in your 2019 fiscal year. So this will occur in either a plus or -4 adjustment. So for hospitals who are choosing not to participate in MIPS at all this year, they will be subjected to a -4 adjustment. For those hospitals that submit at least 3 or more quality measures and have good performance data, those hospitals will receive a positive 4% adjustment. And some hospitals who perform very well could receive up to 12% positive payment adjustment. You can also see here where the payment adjustment increases every year up to 9%, either positive or negative, in the year 2022. And again, more information about this can be found on the QPP website listed. So let's dig into MIPS a little more and discuss each of the 4 categories. As I mentioned, MIPS aligned 3 different reporting programs and added a 4th category. However, participation in 2017 only requires reporting 3 of the 4 categories. First, quality replaces the previous PQRS program. The improvement activities category is the new category. Advancing care information, or ACI, replaces the previous meaningful use program. And the last category, starting in 2018, is cost, and this replaces the value-based modifier program. Each of these categories have specific weighted percentages for how MIPS scoring takes place. Performance in each category will provide a MIPS score of 0 to 100. For 2017 reporting, for payment year 2019, each category is weighted with a total score of 100%. The emphasis is greatest at quality, at 60%, advancing care information is 25%, and the new category, improvement activities, equals 15%. I just also wanted to point out there are some changes expected for next year for 2018 reporting, but also this slide indicates information and differences for hospitals and hospitalists and hospital-based clinicians. Quality and improvement activities are the 2 categories for reporting. CMS stratified this to consider hospital-based providers who have really no control over the EHR vendor that their hospital selects. So considering that, they're removing advancing care information, and hospitalists and other clinicians are only required to report on quality and improvement activities. So next year, we will see that the quality and improvement activities will be reweighted. Again, there will be greater emphasis on quality, and CMS will consider sort of a baseline on cost for determining performance measurements for cost in 2018. So what are the goals of CMS when it comes to quality reporting? Through the development of quality reporting programs, CMS has really kept several key things in mind. The primary focus is to use patient-centered approach to improve patient outcomes. And so how do they do this? The goals provide clinicians with the flexibility to select quality measures that are relevant to their practice and patient population, using different certified EHR technology to maximize their documentation. And through this, the hope is to minimize disruption to clinicians and also to take into account real-world clinical workflows. The goal here is to capture relevant data during the patient encounter and therefore really eliminate any labor-intensive work that's involved with chart abstraction. So for quality reporting under MIPS, there are 271 total quality measures. CMS really considered clinicians, stakeholders, and patients when selecting these quality measures available. Several measures were available for PQRS reporting, so therefore there's not a lot of changes, or clinicians that reported under PQRS previously will still be able to use those same measures. Quality measures available also take into consideration different health outcomes, clinical processes, patient safety, care coordination, also patient engagement, and population health. So looking to the future, eligible clinicians will report 6 quality measures, including 1 outcome measure. That's for this year. An outcome measure is considered the real golden child of the measure types because it shows a patient's outcome after a specific clinical action was taken. I thought that was very interesting that they're considering it the golden child of all quality measurement. Clinicians can select from 26 preset specialty measures, which are standardized by specialty. So for hospitalists or other hospital-based clinicians, there are specialty sets that really are customized to that particular practice. So it makes it a little easier for clinicians to select their measures. Looking at the improvement activities category. Again, this is new under the MIPS program. And the goal with CMS is to measure quality improvement using improvement activities that are identified by the clinician themselves. So the focus is on practice-driven quality improvement in areas like care coordination, beneficiary engagement, again, population management, and health equity. I thought it was very interesting here that CMS really considered the fact that it's important to have clinicians select their own improvement activities because who else knows their workflow, their culture, their patient population better than the clinician itself. Under these improvement activities, there's 92 to select from, and a provider must attest to completing 4 within a 90-day reporting period, and the total aggregate score would be 15%. So let's look a little bit at the scoring for each of these categories a little more in depth. Quality, you'll see, has a maximum weight of 85%, where each submitted measure is worth anywhere from 3 to 10 points. There are also bonuses for reporting outcomes, patient experience, and other related goals. Improvement activities are weighted at 15%, where each activity is worth either 10 or 20 points. So in order to achieve the 40-point requirement, facilities or clinicians must select either 2 or 4 measures to achieve that point total. And then again, this is weighted at 15%. And then for 2017, just to reiterate, cost is weighted at just 0%. So the reason they're doing this is to just establish thresholds for future years. So each measure received either a 1 to 10 point based on any comparison benchmarks. And then that information will be used to calculate the weight for 2018 and future years. This information just shows a little more breakdown as far as the improvement activities and how this is scored. So for each performance category, the score is determined by the number of improvement activities completed. So either you select either 2 or 4 activities where each weighs either 10 or 20 points, and that will allow you to achieve the 40-point maximum. From there, that score is calculated based on the 100% total, and that will give you your weighted percentage where you meet your improvement activity category. So CMS expects that most clinicians will score anywhere for a minimum of 3 or greater, meaning that you'll submit 1 quality measure for 90 days, and each eligible clinician will be earning either a negative or negative or positive payment adjustment. We really recommend that you go ahead and start establishing a plan now and establish a plan for this year's reporting as well as future years. CMS recommends doing at least 7 or 8 of the quality measurements, and from there they will select 6 that reflect your best scores, and this really increases your better chances for the greatest positive payment adjustment available. So I've really given you a lot of information here. MACRA, MIPS, and APMs, it's a lot of confusing information and a lot to really wrap your head around, especially as it's a new quality reporting program that lots of folks are just still getting up to speed on. So the question is how can you achieve success with this? Our recommendations are to really focus on bringing together an improvement team. You can call it your MACRA team or improvement team, whatever works best within your facility. But again, aligning different folks from IT, financial, clinical, quality, lots of different departments to come together and get on the same page about everything. From there, you can identify which providers are MIPS eligible within your organization. And there's a real need to understand these requirements. Who's eligible, who meets those requirements under Medicare reporting. Pick your pace. Which option is going to work best for your facility, your clinicians, and really consider if those payment adjustments, whether negative or positive, how that's going to have a financial impact to your bottom line. From there, you can identify at least 6 quality measures. Again, CMS and I really recommend selecting 7 or 8 or even more. That way you have a couple to fall back on. That way you can, evaluate where your best scores are, where you're performing the best. Also, it's important to begin identifying those improvement activities. Again, this is a brand new category under quality reporting. So the good thing is that CMS considered the improvement activities are typically activities that hospitalists and clinicians are already doing. They're already implementing those in their daily practice. So those shouldn't be difficult to select, but it is really important to select those that are relevant and meaningful to your clinicians and your hospital culture. And then lastly, put an action plan in place and follow through. So Iatrix Systems has professional services available to help. We have a service offering called MACRA Assist. Our consultants are experts in CMS regulations, and we're here to work with your team to evaluate the best reporting options for your facility. We'll also help you identify which hospital-based clinicians are required to participate in MIPS this year. We'll provide certain education and guidance for selecting measures that are relevant to your clinicians. From there, we'll provide a gap analysis or an assessment of the measure selection based on your current workflow and show where your clinicians are not meeting up to specific reporting requirements for a particular measure. We'll also work with your team to develop a plan, identify any remediation that's required, educate your staff, and follow through with an attestation plan for your organization. So professional services, again, we're here to help. We're really excited with the MACRA Assist offering, and we found that it's very beneficial for those facilities where it's just lots of new information. The regulatory programs can be very confusing, especially when it's a new reporting requirement within hospital organizations. So we're here to help. And with that, I'd just like to say thank you for attending today, and we will go ahead and open up the chat for any questions, and we'll do my best to answer all your questions that you have at this time.
Okay, thank you, Cindy. I do want to remind everybody that if you do have a question, just enter it in the question section of your control panel, and we do have quite a few here for you. The first question is, our hospitalists are part of a group, so do each need to see 100 patients, or is it 100 patients per group?
Each of those would see 100 patients. Now, each of those would be required to report. Now, the other thing, when you're considering the improvement activities, you could select just improvement activities that would apply to one or just a few of those hospitalists, but each of those that see more than 100 patients and bill more than $30,000 are all required to report.
Okay, our next question is, if all the ECs are contract-based, what will be the responsibilities of the hospital?
That would be something for your hospital leadership to look into. If the billing originates from your hospital NPI or tax ID number, then the hospital is responsible for doing that reporting. If the hospitalists are part of a group or a consulting organization that outsources the hospitalist, typically those organizations will do the reporting on the hospital behalf. But I do encourage you to speak with your administration and get the answers for who's responsible to do that reporting for those hospitalists.
Okay, the next question is, will the reweighted quality and improvement activities only be applicable to hospital-based providers? Our employed providers such as FP, OBGYN, GI, and hospital-based providers all bill under one TIN. Will the quality rate be 85%?
Yes, that is correct. Now, the clinicians that are hospital-based that only practice for the hospital and they don't have their own, clinic practice, those providers are eligible for MIPS reporting under the hospital under that tax ID number or the TIN. Now, if they practice within their clinic or a physician-based practice, typically those clinics will have a separate TIN or tax ID number. So I guess the reporting is the responsibility always ties back to that tax ID number and who holds that number.
Okay, here's a similar question. Our ER physicians and anesthesiologists are not employed by the hospital. Would those physicians be responsible for submitting their own data?
Those physicians would be responsible to submit under the company in which they are employed. But again, I would encourage and make sure that whoever their employer is, make sure that those folks are up to speed and have a plan in place.
Okay, let's see. Our next question is, does CMS have a program that you submit the results?
At this point, it's going to be similar to the attestation website. So I didn't really go into that, but the reporting deadline is the same as other quality reporting programs for hospitals, where the reporting would be it's either February 28th or March 13th of 2018. So that would be the reporting deadline, and those folks would be held to the same deadlines and reporting requirements as the other programs.
Okay, if an organization reports via GPRO web interface in 2018 for year 2017, are they required to report on all 15 measures?
Yes, that has not changed.
Okay, and hospital-based clinicians are required to report only quality and improvement activities for 2017, or did you say that starts in 2018?
No, they are required to report quality and improvement activities in 2017, and then cost will be added in 2018.
Okay, how do you attest for MACRA similar to reporting for meaningful use?
Yes, that would be correct. So CMS will have an attestation website, and like I mentioned, next year in 2018, as we get closer to the reporting deadline, more information will be coming out as far as the where to go to attest and where to submit your information, your data.
Okay. To what Medicare payment is the penalty applied? In other words, pro fee, DRG, etc.
There's a lot of information out there about that. I would like to just take that question and I'll follow up individually with that person, Amanda. I just want to make sure that I provide the accurate information, and there have been some changes related to that.
Okay, the next one says, when is reporting required to be submitted in 2018? And it is on the QPP website.
Yes, so reporting requirements, it's a ways away, but as it stands now, it will be February 28th of 2018. It will be the same reporting deadline as the other reporting programs for the hospital-based EHR incentive program and IQR reporting.
Okay, and what is an improvement activity?
Okay, great question. So an improvement activity, again, it's one of the new categories added under the MIPS program. So these activities are those that are selected by the clinician themselves. There's 93 improvement activities to choose from. And many of those, like I mentioned, many hospitalists and clinicians have improvement activities that are already part of their daily workflow. They just haven't been, named or included under an activity, improvement activity program in the past. So I guess just to give you a couple examples of what some of those would be, like the identification and timely reporting of abnormal lab tests. That would be an example, or providing a healthcare guide for your specific community. Other surveys related to patient experience or patient satisfaction. Some of the behavioral health screenings that ED physicians and physicians do related to tobacco cessation or alcohol drug use. Each of those are different examples of improvement activities.
Okay. We report as a group. Mostly physician offices and our hospitalists fall in the same TIN. We are at a loss of how we are supposed to get the hospital data, which is in a separate EHR.
Okay, I may need to follow up with that person. It depends on if the data is collected within the hospital EHR or if it's collected within the clinic EHR. Regardless, for reporting for hospital-based physicians, that information needs to be collected within the hospital EHR system or other methods of data collection and then reported under the hospital's TIN. I'd be happy to follow up with that question as well.
Okay. All right. In a previous conversation, it was stated that the hospital will take a hit if the EC did not report and indicated the hospital is required to report for like contracted hospitalist anesthesia ED. Can you please clarify?
So that is correct. If there are hospital-based providers, meaning your ED physicians or anesthesiologists, any of those clinicians that are employed or based within the hospital, those folks are required to participate in the MIPS program. And if they don't select and submit at least 3 measures, then there will be a 4% negative payment penalty or payment adjustment.
Okay. What is the difference in reporting methods? Examples are registry and EHR. Is this just ways of getting our reports to be able to enter into the website you are speaking of?
Yes, that is correct. There's a lot of information on the QPP website that goes into different options for how to report. So I can send out additional information about that, or you can always reference the QPP website that goes into all the different options for how to submit your data.
Okay, and would two groups of providers, clinic providers and hospitalists from the same hospital under the same TIN be reported together or as a group or individually?
They would be required to report under the same TIN, so as a group.
Okay, and this question is, I guess, referencing an answer you provided. Payment adjustment for who? The hospital or the eligible clinician?
So the reporting, when we're speaking to hospital-based reporting for those clinicians, then the adjustment would be under the hospital, whichever TIN that provider is submitting under, then that's where the payment adjustment is going to fall back to. So if it's a hospital-based clinician, under that TIN, that's where the payment adjustment will take place.
Okay, great. These are some very good questions. I do thank you all for submitting them, and that's all we have at this time.
Okay, thank you, Amanda.
All right. I do want to thank everyone for attending our webinar today. As a reminder, you will have the opportunity to fill out a short survey to tell us how we did. And this survey will appear when you leave the webinar. For your time, your name will be entered in a drawing to win a $100 Amazon gift card. And all of these drawings are held at the end of each month. Please follow us on social media and our blogs for healthcare IT updates and to interact with your peers. If you would like more information, please contact your iAtrix Systems account executive, or you can send an email to info@iatrix.com. I'd like to thank Cindy, and once again, thank everyone who took the time to join us today. I hope you have a great day, and this concludes our webinar.